Hi everyone, my name is Veronica Rivera, and I'm going to be speaking to you today about office-based dementia screening beyond the mini mental status exam. I am an outpatient geriatrician here in the department, and I mostly work at the Martha Stewart Center for Living Uptown here in New York City, where I'm also the medical director. But I also see patients at a federally qualified health center called the Institute for Family Health, where I see patients in that setting as well here in New York City. So in terms of objectives for today, we are going to be describing common dementia screening tools, demonstrate how to administer and score 2 brief dementia screening tools, and then increase awareness of dementia screening tools for special populations. So a little bit of background. In terms of dementia screening, the USPSTF, or the United States Preventative Services Task Force, did conclude that there was insufficient evidence to recommend for or against routine screening for dementia for older adults. A couple reasons they cite: no, there is no cure. There's no reasonable test for early detection in the asymptomatic phase. And there's no empirical evidence that screening improves decision-making and whether interventions have a clinically significant effect in persons with earlier detected cognitive impairment. So that being said, despite this recommendation, we do recognize that there are a lot of patients that we are seeing in our patient population of taking care of older adults with patients who do have dementia, and identifying and knowing about these cognitive impairments can definitely have significant impact on patient safety at home, caregiver burden, and also just the medical management of our patients, right? So can they adhere to their care plan, take their medications, go to specialty appointments? All of those in a medical setting can definitely be affected with cognitive issues or dementia. And so I do recommend screening and getting comfortable with some of these screening tools that we're going to be talking about today. And we do have a high burden in our country, unfortunately, of patients who have dementia. In terms of numbers, there was about 47 million globally with dementia in 2015, and that's expected to triple by 2050. And there's a high cost associated with that. In terms of prevalence, the prevalence does increase the older our patient population is. And this statistic has about 15% of patients over 70. I've also seen other statistics ranging, citing that patients who are in their 60s, maybe 5% prevalence, but that does double every 5 to 10 years. And so some of our demographics of our seniors in their 80s and 90s could be a higher prevalence of about 40%, for example. So definitely higher rates the older our patient population is. And there's a significant monetary cost attributable to patients who have dementia. And in terms of 2010, the monetary cost was about 250 up to 250 billion estimated, and Medicare was a significant payer of that. The global cost in 2015 was about 800 billion. So this is quite a huge prevalence and burden to our health systems and our societies. So why might we not be doing it? In general, I think most practitioners identify it as important despite the USPSTF guidelines. But there are some significant barriers that are well documented. One is time. Absolutely, we are all very familiar with a lot of patients, a lot of time constraints in the outpatient setting, limiting our ability to spend as much time with our patients as we would like to. So time is a huge issue. And sometimes we have lack of staff or support who can help us with doing some of these screening tests. There's also a real fear of offending patients. So I have definitely had patients where presented what I thought was a pretty benign screening tool, but were quite offended by this being asked. So figuring out how to normalize this is important as we continue to introduce dementia screening to our patients. There's also, for our patients with dementia, an increased risk of hospitalization, and like we talked about before, a high burden of care. And many of us have started to incorporate into our practices doing the Medicare annual wellness visit, and dementia screening, fortunately, is part of the annual wellness visit. Before getting into some of the screening tools a little more, I want to step back and remind everyone about what is the diagnosis of dementia. So going on, based on the DSM-5 criteria, the nomenclature actually changed from dementia to major neurocognitive disorder. And so that is important to note, as technically per DSM-5, we're talking about major neurocognitive disorder. And the definition or the diagnosis includes a decline in one or more cognitive domains. So this might be in learning and memory, language, executive function, complex attention, perceptual motor, or social cognition. And to have major neurocognitive disorder, these impairments or decline in the domains have to be also in conjunction with deficits that interfere with function, and not in the context of delirium or not explained by another mental disorder. And so when we talk about function here, it's really important to make sure we're getting a good functional assessment, particularly early on, of a patient's instrumental activities of daily living, or their IADLs. So their patient's ability to use a telephone, do their cooking, cleaning, laundry, manage their medications, manage their finances, use transportation. Those are the IADLs that we are looking to see if there's a change in prior that might signify that a patient now has major neurocognitive disorder or dementia. And so that's really what we're trying to get at here. So a case, a really quick one. Mrs. Smith is a retired 74-year-old with past medical history of hypertension. She comes with her son, who shares her concern about her memory, and Mrs. Smith jokingly says she's just been having some senior moments, but she's up to date on health maintenance and labs. Your physical exam is unremarkable, and your next patient, of course, has arrived and is ready to be seen. So what will you use for your cognitive screening tool? And so the takeaway here is there are many dementia or cognitive screening tools. I will, in the next few slides, provide you with some references that go over the list of different assessment tools that are available currently. But we're going to ultimately highlight over the course of the talk some that are brief and easier to use. And then also I'll be highlighting some more commonly used ones, even though they might take a little bit longer, and then some new and up and coming ones that you might want to be aware of. In terms of these, the background, in terms of brief instruments, 12 brief instruments have been studied more than once in a well-designed diagnostic accuracy studies that evaluate their ability to detect dementia in primary care. And so these two references here from USPSTF and from JAMA. We pulled out these few slides and list of screening tools. So just want to reference them here. The mini mental status exam, clock drawing test, verbal fluency or category fluency, the memory impairment screen, and the mini cog are some of the faster ones that we will review today and how to do. A couple other ones here that you will see, the informant questionnaire on cognitive decline, and some of these other ones that are really not widely used, but here for your reference. And then in this JAMA article, again, showing you here some of these common tools, the time it takes to administer them, and what are some of the domains that are being assessed in these assessment tools. And so I'll point out again here, the clock drawing, 3-word recall, mini cog, memory impairment screen. And then later in the talk, I will reference and show you the AD8, the GP cog as well. And this is really more for your reference. This shows you also a continued, the MOCA, we will look at the mini mental state exam, and showing you the time to administer, and also the domains that are being assessed. And then a couple other references here. In this slide, you're looking at some of these screening tests, categorized by very brief, and longer, more detailed, and the sensitivity and specificities as well. And again, we'll be highlighting today some of these as we move along, but for your reference here are some of the sensitivity and specificities that are important to think about as you're using them. Okay, so the mini mental state exam has been widely used for a long time. Often for many of us, the main assessment we were introduced to in medical school, for example, and is scored out of 30 points. I'll remind everyone here what some of the components are, but some of the shortcomings of the exam as well. Out of the 30 points, a third of those points, or the first 10, are just orientation alone. So location and time specifically. There is a little bit of registration. So name 3 objects, repeat them after you finish. Attention, 5 points for the serial 7s or spelling world backwards. Recall, so memory recall of those 3 words from the earlier in the exam. There is a little bit of language and praxis with naming the pencil, watch, repeating no ifs, ands, or buts, following a 3-step command, and reading and obeying, close your eyes. And then lastly, for visual spatial, there's a point for copying intersecting pentagons. The MMSE, as you can see here, is not quite that sensitive. It's only 81% sensitive. So we can miss dementia in patients who were using the MMSE, and very, very often miss MCI. The score ranges and cutoffs vary based on level of education as well. But especially for patients with high level of education, there is a risk for missing cognitive impairment. And it may not be as good for other types of dementia like vascular, frontotemporal, and Lewy body, as some of the cognitive domains are not really well assessed on this exam, like executive function, for example. A couple other challenges. There's only a fair positive predictive value. There are some limitations by age, education, and ethnicity, as I mentioned before. Also, it is technically proprietary, meaning we should be paying every time we use it. And it can take sometimes as long as 10 to 15 minutes, depending on the patient. In terms of other additional screening options that are brief, I will be highlighting first, the mini-cog, the clock drawing test, memory impairment screen, and verbal fluency. And then we'll get into some of the longer ones in the later part of the talk. So the mini-cog, I'm a huge supporter of. I think it's a great screening test, and it's probably the fastest and easiest thing you can do in a busy ambulatory practice. I'm always trying to remind my learners that it's so fast to do and can get you a lot of really useful information. There's only two components, a 3-item recall and a clock drawing test. And how do you do it? So first is you want to give a patient 3 words to repeat and then remember. Of course, you want to make sure you introduce this in a sensitive way. I usually recommend either incorporating it into my new patient physical exam and standardizing it as something I do with all patients, or making sure you say something along the lines of, this is something I do commonly with all of my my patients in the outpatient setting, just to look and check for memory issues. So once you introduce the assessment, you can give the patient 3 words to repeat and ask them to remember them. So you could say, listen carefully and remember these 3 unrelated words. Have the patient immediately repeat the words back to you to confirm that they remember. So the 3 words I've used are ball, flag, tree, and those are the 3 words I learned as a student, and the 3 words that I remember every time, but you can use any 3 distinct words. Apple, table, penny is another commonly used group of words, but really you can use any 3 distinct words, and hopefully they're unrelated. Then after you ask the patient to repeat, and then try to remember those words, you can ask the patient to draw the face of a clock. I usually give patients a blank piece of paper and ask them to draw a full clock. Some people prefer to draw a circle or give a paper with already a circle drawn, but you could do either, but technically I usually give them a blank piece of paper and like to see how their motor skills. I have seen patients with Parkinson's, for example, draw small clocks that shows micrographia. And then after you ask them to draw the face of a clock, I ask them to draw all the numbers and the hands of the clock with the time 11:10 or 8:20. Many people still say 10 past 11 when you're asking for the time. So you can do either. And then you can repeat the steps, but really no additional instruction should be given. And if they can't draw the clock within 3 minutes, you should move on to the next step. These are examples of some of my favorite clocks over the years. This patient up at the top left, she was still working as 90-year-old doing coat check at a store. This person over here, she drew the months around the circle versus numbers. This person over here was a psychologist who also had an alcohol use disorder and high level of education, but you can see here he drew with Roman numerals, but had the time wrong. So a slight abnormality there, which was significant for him. And then in terms of the scoring, you get a point for each word that is correctly recalled, and you get 0 or 2 points for the clock drawing test. So if the clock is completely normal with the correct hands and numbers, it is a 2-point score. If it is abnormal in any way, it's a 0 out of 2. And so a score that's between 3 to 5 in total is technically a negative screen for dementia. And this is one piece of your information, but if you have a negative screen and a reassuring history, someone who's really functionally independent, that could definitely reassure you and you could move on. An abnormal mini-cog score with has a sensitivity actually of 91% and a specificity of 86%. So it is, again, a very quick and easy tool, but actually gives you some pretty useful information. So that's the mini-cog. The other one, brief screening assessment I'll go to next is called the memory impairment screen. And so this is a 4-item delayed memory test assessing free and cued word recall, and it's scored out of 8 points. I have to say I don't use this one so much in practice, but I'll show you a version of this that's now embedded in the MOCA. But this is a pretty easy screen to do and might be useful for patients who have low level of education as well. So you're going to ask the patient to, you're going to give the patient 4 words from 4 different categories, and you'll have the patient initially read the 4 words. And then you will cue them and tell them what category those are in. And then in 2 to 3 minutes, after waiting, you can have them do other tasks in between. Then you will ask for the recall. So for example, if I was the patient, I would read the words red cross, saucer, checkers, and telegram. And as the provider, I would say, which one is a game? And I would say checkers. Which one is an organization? The patient would say Red Cross. Which one is a type of message? Telegram. And which one is a dish? Saucer. And then you would wait the 2 minutes and then ask them to recall the 4 words. As many as for every word that the patient remembers without cueing, they get 2 points. So that's the free recall. If I remember Red Cross, checkers, telegram, but I didn't remember saucer, if I said one of them was a dish, and then I remembered saucer, then that would be 1 point. Okay, so that's how you would do the memory impairment screen, and that example would be a 7 out of 8. In terms of sensitivity and specificity, if someone scores below 4, that is an abnormal screen, and it has a sensitivity of about 86%. So comparable to, and maybe even a little better than the mini mental status exam. Another quick and easy exam to do is animal naming. And again, for patients with low level of education, this is a nice one to consider. You can ask the patient to name all the animals they can think of in 1 minute, any kind of animal, birds, fishes, insects, all the dogs they can name, those are counted. And these are the cutoff scores and the sensitivity and specificity for each of these. So if they can remember 8 or less, that's a 50% sensitivity, and 13 or less, 85% sensitivity, if you use that as your cutoff. All right, in terms of screening tests, looking at these all together, some of the sensitivities and specificities, MMSE, mini-cog, memory impairment screen, and animal naming. You have those here as a summary. And then just in terms of clinical pearls, the MMSE is most sensitive for patients with Alzheimer's, but for other dementias, not as sensitive. Dementia can be present but not noticed if you're not really screening or looking for it. So I definitely have been fooled before by doing a very simple mini-cog. So important to incorporate screening into your practice as much as possible. It's often unrecognized and undocumented in the primary care setting. And these 3 very brief screening tests can even be incorporated by your staff or other team members to really help increase the rates of screening. But given that they're so simple and quick to do, either you can do them or train your staff to do them. And then next, I'm going to go over a couple other screening assessments that are available. So the first one here, GP-COG, 88, MoCA, SLUMS, and then also another one called RUDAS. So I'll share those over the next few slides. So for the general practitioner assessment of cognition, the sensitivity and specificity here about 85 and 86%. And this is a cognitive screen that also includes informant questions. So you need another person as well to provide some history. And it has an online component. So the patient will be asked, what is the date? Mark in all the numbers to indicate the hours of a clock, something that happened in the news recently, etc. are some of the questions. And then there's an informant interview. So how is the patient compared to 5 or 10 years ago? And this gets into some of the functional components of the cognitive issues. Is he or she having more difficulty remembering things, more difficulty recalling conversations from a few days ago, more difficulty finding the right words, so some word finding difficulty, difficulty managing finances or personal affairs, managing medications, and transportation. So again, some of those IEDLs we talked about earlier on. So that's a screening assessment you can look at. Another one is called the AD8, and this one is predominantly an informant screen, but also can be used by the patient and answered by the patient. And for each item, the score is 1 point if the patient says yes, there is a change. And you want to add up the total score. The max score is at 8. And so if the score is 2 or higher, then this is concerning and more further workup should be looked at. And has a sensitivity of greater than 84%. So as you can see here, some of the questions are a little bit dated, but these are, again, getting a lot at the functional components and impairments for our patients. So 1, problems with judgment, making decisions, bad financial decisions, problems with thinking. 2, less interest in hobbies or activities. 3, repeating questions repeatedly. 4, difficulty learning how to use a new tool, appliance or gadget like a VCR, computer, microwave. 5, forgetting the date, month or year. Difficulty managing finances, remembering appointments, and daily problems with thinking or memory. So again, another option, particularly for patients with low level of education or with low insight to their cognitive issues. And then another very popular but longer assessment tool, again, is the MoCA. So the Montreal Cognitive Assessment has gained a significant amount of popularity and use, and is a very common one we are here using in our sites. It was created predominantly for screening, to help screening for mild cognitive impairment. And the average MoCA score for patients with MCI is about 22. And then the average score for patients with mild dementia is 16, Alzheimer's disease. So there's some sensitivity and specificity here with these cutoffs. I tend to forget these cutoffs myself, and again, varies a little bit based on level of education, but these references are here for you. But I'm really using this MoCA often to follow up prior abnormal mini-COGs, and trying to use this as part of my overall evaluation for someone's cognitive assessment. In terms of the components of the MoCA, it's nicely illustrated on the exam itself, what cognitive domain is being tested. So up at the beginning, when you're first starting, you can see here visual, spatial, and executive function is in the first few questions. So the trails here, alternating number letter going in increasing order, visual spatial here, copying the cube and then drawing the clock. Of course, you can see here there's a difference where there's 3 points for this clock draw compared to 2. There is a language component where you're asking them to name animals. The memory component, recalling 3 words. There's no points for registration of those 5 words, but later the points are given for recall. Before I go to the next page, also important to go to the website because you can also there find all the versions of this exam in multiple languages, but also very detailed instructions on how to administer the exam and with suggested language on how to introduce and explain these assessments. And then over here, the second half here, there's attention where you're asking them to read digits, repeat digits back to you, reading a list of letters and asking them to tap every time they hear the letter A. Serial 7s is also in this exam. And then more language skills here with repeating sentences and fluency, asking to list all the words that you can think of that begin with the letter F. There's abstraction, and then lastly, the recall and orientation. And then I point out here what we talked about, what I referenced earlier, the memory impairment screen. There's a memory index score now embedded into the MoCA. And so this score is out of 15. And so you can get 3 points for every word that you recall without category cues or multiple choice cue. And then you can get 2 points for each word you recall with category cue and 1 point for multiple choice cue. So if, for example, I don't remember the word face, but you tell me it's a part of the body and I still don't remember it, but I remember when you tell me arm, face, or leg, and I say face, then I get 1 point out of 15 here. And so you do that for each of these 5 words, and that out of 15 will calculate your memory index score. And that is separate than the MoCA score total. And so that is a new addition with this version of the MoCA that came out recently. Individuals who have mild cognitive impairment, there was a report that came out that says that they studied and showed that patients who had MCI and memory index scores of less than 7 had a higher risk of conversion to Alzheimer's dementia. So within 18 months. So that is another piece, how to also try to maybe think about that information. So if you have a patient with mild cognitive impairment and a low memory index score, that could potentially be predictive for conversion to dementia. A couple other things to keep in mind regarding the MoCA. A few years ago, it did come out a recommendation for training and certification. This has been available on their portal since 2019. Per their website now, if you want to continue to use it without risk of being with administration scoring or interpretation errors, you should take the assessment. Otherwise, you'll be at risk for misdiagnosis and liability. But updated in 2021, certification is now free for students, faculty, and academic researchers, which is before you did have to pay to get certified. And there's also an ability to be exempt if you work at an academic institution or are in training. Okay, so that's the MOCA. I will come back to the MOCA when we talk about special populations. But for now, I just want to comment on the SLUMS, which is the St. Louis University Mental Status Exam. For those who work in the context of the VA administration, this is the most widely used screening assessment tool for the Veteran Administration. And so I also scored out of 30 points. A score cutoff less than 23 is abnormal. And these are the sensitivity and specificity scores. This is the exam itself. Some orientation questions. A couple other things that are different here. If you have money, how do you spend it to buy a dozen apples and a tricycle? Animal naming is in here. Word recall, clock draw. So there are some overlap questions as well. And then there's a story here that you also have to recall some questions. And then briefly, I am not an expert, but there has been a little bit more acknowledgement of in the field of this assessment tool called the Rowan Universal Dementia Assessment Scale. RUDAS came out of Australia. A short cognitive screening instrument designed to minimize the effects of cultural learning and language diversity on the assessment of baseline cognitive performance. I'll just leave this here more as a reference if you have time and wanted to look at it. This is a tool that I think has been gaining a little bit of popularity in certain areas. I'll say here in New York City or in our Mount Sinai sort of network, we have not been using this quite at all, but I've heard of it being used in other areas of the country. And again, some similar overlap, but there are definitely some newer components in this exam, a little bit more in the visual spatial, on motor skills and praxis. And then you can see here visual spatial wise, the copying the cube is an overlap from the MOCA, but there's a little bit here on judgment as well. Memory recall, language skills with the animal naming as well. So again, some components similar, but a couple other different aspects here. And then I do want to focus a little bit on special populations. I think this is really a challenge as we are doing these assessments in our patient populations that we are often working with. So one is low literacy. So for patients who have low level of education, this can be challenging to assess, especially if you don't have prior baseline assessment tools conducted. A couple ones to keep in mind, the MOCA has a version called the MOCA Basic, which I'll show you in a little bit, which is 81% sensitive for MCI. There's more use of pictures, pattern recognition instead of written word. There's also, you can still use the MMSE, which I do sometimes use for patients with low level of education. And then a couple other ones that I'm not as familiar with, but are available: cognitive ability screening instrument, Eurotest, and Phototest. And then visual impairment is also a population that we might encounter. The MOCA also has a version for patients who are blind or visual impaired, but things like the animal naming could be conducive to patients with visual impairment, or the mini-mental, or the MOCA, but just omitting the vision-specific areas. These are some screenshots from the MOCA Basic. You can see here there is a trails for executive function, but does not include letters. There is word recall, word fluency, orientation, and visual spatially, And language-wise, there is some identification here of these objects in this drawing, naming these animals, and then attention, following the instructions and saying all the numbers that are in certain shapes. This is a screenshot of the MoCA blind. Again, another version to consider. And there is one for hearing impairment as well. And then just in general recommendations before we conclude, it's important to normalize how you introduce this. I mentioned this before, that even just the very brief mini-cog, how patients perform and how they receive it, it might be sensitive. So you do want to make sure you're normalizing and asking permission. I do have some patients who really don't want to know if they have dementia. And so together we decide to not screen if that's really what their goals and preferences are. Of course, there may be instances where you do really want to know that information and sort of building rapport and building trust so that you can get patients to agree. But it is ultimately important to ask if patients want this test, just like you would ask them, do they want a CAT scan? So something to keep in mind. You want to make sure patients are as comfortable as possible. Anxiety and other mood disorders can definitely affect how they perform. I do often recommend asking patients if they want their family members to step out and wait outside during the assessment, just for their comfort. Of course, it can be also a good educational or learning opportunity for family members to observe, but ultimately the patient preference and their comfort is the priority. And then languages. Of course, you want to, as much as possible, do this assessment in the patient's native language, and if necessary, use in-person translation. As with all translation, ideally you're not using family members. Ultimately, you also really want to make sure family members are not helping during the time you're doing this assessment. We have used also video translation, which is definitely a little bit better than audio only translation. But this can definitely be a limiting factor if you don't have staff or providers who can do this testing in the language of the patient. And then ultimately, I always recommend asking them permission to review the results, just like you're asking permission to do the screening in the beginning. You want to ask permission to go over those results. And in summary, screening for dementia or major neurocognitive disorder is a very important skill for practitioners who are caring for older adults. There are many screening tools available, some more brief than others, but those brief ones particularly important to practice, be comfortable with, especially if you work in a setting that has very limited time available. So it's important to get comfortable how to do these also efficiently and effectively. Question number 1. All of the following are validated office-based screens for dementia with an average administration time of less than 5 minutes, except A, verbal fluency testing, B, memory impairment screen, C, mini mental state exam, or D, mini-cog. And the correct answer here is C, the mini mental state exam, because this one is an average of 7 to 10 minutes to administer. Question number 2, which of the following is true regarding the mini-cog office screen? A, includes verbal fluency assessment. B, includes delayed recall and clock drawing. C, primarily assesses orientation. Or D, verbal cues provided for failed recall. And the answer here is B. As we reviewed, it's a 3-item recall and a clock drawing test, drawing the time 11:10 or 8:20. And this test does not include verbal fluency or orientation assessments, and they're not cued to remember any of the 3 items for recall. And thank you so much.